You've read, heard, and watched plenty of stories about the heroin epidemic destroying lives across the country and right here in Louisville. Dr. Erika Ruth is the director of the addiction program in the Department of Psychiatry and Behavioral Science in the UofL School of Medicine, and she knows firsthand the impact that heroin is having on families right here in our community. Dr. Ruth, welcome. Glad you're here.
Thank you for having me.
All right, well, tell us a little bit about the heroin problem. Is it as bad as we keep hearing in the media? Is it as bad?
Unfortunately, it is. It definitely is. It is touching all walks of life. There is no socioeconomic status that protects you from it. Again, oftentimes it can start as abuse of pain medications that are prescribed, and then the body becomes used to them, and from there, use increases. At this point, oftentimes doctors will not prescribe anymore when patients start running out early and they feel there is no option for either pain control or fear of the withdrawal symptoms, that they are willing to turn to heroin.
Wow. So in an average family in Louisville, you might have somebody that's got a job, a couple of kids going to school, average person, maybe has back injury, starts on OxyContin, manage the pain, and after that, no more OxyContin, they turn to heroin. That's pretty much, I think, what you're telling me.
It is.
Wow.
It is. There are people who start with heroin, but that is not always the case. It can be somebody who holds a job, has children, is just trying to get their pain managed, and many people who start on these pain medications have not even realized that they are so addictive and have the potential to take over your life.
So you're a psychiatrist at UofL. So where do you fit into trying to manage and help this heroin epidemic that we have in not just Louisville, but everywhere?
I am specialized in addiction, so I am an addiction psychiatrist. There are a few of us here in the city, and I went through the training program, fellowship training program here at UofL that we have for this specialty. It allows me and the others who have gone through it to be able to see the dual diagnosis part of it. And dual diagnosis is where the interface of mental health and addiction meet, and how we treat both, and how important it is to treat both. Many people who treat addiction are not as comfortable treating mental illness, and many people who treat mental illness are either not aware of the brain chemistry or the effects that addictive medicines can have. That's where I come in.
And do they often, and at least when it comes to heroin addiction, do they often mesh? Is there a point where mental illness and addiction meet and cause the problem? Or are they two separate issues that kind of converge?
Yes and yes.
Okay.
There are those who start with whether it's a traumatic incident or prolonged traumatic incidents in childhood or something in later adulthood, and they turn to drugs to numb this out, and then they haven't taken care of those. Some people also have depression, anxiety, and don't know how else to treat it other than drugs and turn to that. And it works for a period of time. People wouldn't use drugs unless it worked. Unfortunately, the toll that it takes and how much it takes over the brain becomes not sustainable. The other issue becomes there's a lot of traumatic things that happen. There are a lot of traumatic things that happen for people who are on the streets. And so then depression, PTSD can develop from that. And so whether you start with it or whether you end with it, there is likely a mental illness component that does need treating.
Okay. All right, we're talking with Dr. Erika Ruth, who's the director of the addiction program in the Department of Psychiatry at the University of Louisville. What is an example of someone that you have treated? Now, I obviously don't want their name, but give me an example of, I'm going to call them typical. There may not be such a thing as a typical addict, but what is the typical addict that you would treat? And who are they? What do they look like? Give me an example.
Again, typical is kind of a funny word because they come from, they can be 20-something young women. They can be men in their 60s. I would say initially when their disease is significantly taken over, when they are very severe, what sits across me is somebody who is willing to take other people's medications and no thought to the risk of it. Somebody who is willing to go to the street and buy anything off the street that might change how they feel. Again, they are desperate enough for this numbing or even to feel better that whatever else might be in it doesn't even matter. Again, it's a certain desperation that comes from it. Again, if they come to me and they are truly ready for the recovery work that it takes. Again, my job is more just a facilitator of them doing the work to become sober. I can't make anybody sober, but if they are, then over time, what we often see is somebody who is able to be honest if they should lapse. They can actually say, look, I've been having cravings. Look, I had an episode or an incident. And my job is to, as well as my therapist and my residents, our job is to say, okay, what happened? And how do we combat that next time? How do we build you up so that next time you have this opportunity, that's not the choice that you make, or you at least have a choice, because at this point they may not. And over time, they are able to hold a job. They are able to, many of them have lost their children, and they're able to actually get visitation. And some of them I've seen actually get their kids back when they've had successful sobriety.
That was my next question: is what is the impact on a family day to day, on a family that has a mom, dad, brother, sister that's an addict in the house?
The emotional toll that it takes is a destructive force. It's an amazing thing. Again, people who have someone who has addiction in their family, it's tragic for those around them. It's not, it is obviously heartbreaking for the person who is suffering from this, who cannot make the choice to care for themselves or their family. But for the actual family members who watch this and can't help them, who do everything they can, but that leads them into the enabling realm of things where the addiction just takes over more and more. I consider addiction kind of the devil on the shoulder, telling this person what to do. You could use a little bit more. It will be different next time, and you'll be able to care for them then. Just do this one thing this time. And so we see family members who stay with patients who have addiction, people who have addiction, and they are worn down. They feel helpless. They end up with their own depression and anxiety over the things that they see and where the money goes, and having somebody go out all night and not come home. There is often
is there help for those families? Is there anything out there for someone that is worn down, married to an addict, or mom or dad? What should they do, I guess, is the question.
The first thing I would recommend to people, because it's free and it's in the community, is Al-Anon, actually. A lot of people don't even think of this as an option. They say, I'm not an addict, I don't need these meetings. What Al-Anon offers is a place to go to talk to others who are struggling with their role in this. Oftentimes, family members feel guilty, they feel responsible, they feel helpless, and talking to others who are also feeling this way or have come to the conclusion that it is not their fault and that they can also take care of themselves and don't have to give up themselves to try and care for the other person is the place to go. So
it's support, just not for the addict, but for the family.
Correct. And for our patients, we don't have anything specific for family members, although that is not a bad idea. When as part of the Suboxone program that I run, patients are required to go through therapy every 2 weeks or 4 weeks, and I recommend, and so does our therapists, that they bring in family members. They communicate with each other. They talk about the impact that it has had on them in a safe place where somebody who has suffered from addiction can hear it and process it without that guilt and shame tearing them down back to a place where they want to use.
We've got about a minute left here. What's the percentage of folks that go through treatment and therapy with you that relapse? Do you know? Ballpark?
Sadly, again, nationwide, probably about 85% of people relapse.
Wow.
Again, with maintenance therapy, such as methadone or Suboxone or Vivitrol, the percentage does lessen. But the pathway that this creates in the brain that hooks them, takes them back out. The difficulty with gaining coping skills that they haven't in the past takes them back out. Just because somebody relapses doesn't mean they don't come right back to getting help. This is the nature of this disease, is a relapsing and remitting disease.
But if you realize it, and if you realize it quickly, you can get back on the train to getting better, right?
Correct. One thing for patients with addiction to realize is just because you lapse, just because you slide off one time or a couple of times, does not mean you have failed, does not mean you are a failure. It means that whatever led to that needs a little shoring up.
All right. Dr. Erika Ruth from Department of Psychiatry at the University of Louisville. You've been very interesting. I may have to have you back on the program here in a couple of months just to talk more about this.
Would be my pleasure. Thank
All right,
you, Mark.
appreciate it.